Well, good evening, and welcome to this year's John C. Marienau Symposium. Pleased to see you all here this evening. It is a real pleasure and a privilege for me to introduce our keynote speaker this evening, Jeffrey P. Gold, MD. Dr. Gold is a nationally recognized leader and tireless advocate for transforming higher education, academic medicine, and healthcare delivery. He became the 8th Chancellor of the University of Nebraska Medical Center, Vice President of the University of Nebraska System, and Chair of the Board of UNMC's Principal Clinical Care Academic Health System Provider, Nebraska Medicine, in early 2014. As UNMC's Chief Executive Officer, Dr. Gold is responsible for all aspects of campus leadership, program quality, and operations, including 7 colleges, numerous institutes, and a staff and faculty of about 5,000 and 3,800 students. Additionally, Nebraska Medicine has 6,500 employees and an operating budget well more than $1.5 billion. The combined economic impact of the 500-mile campus academic health center exceeds $4 billion. In April 2017, Dr. Gold was also named Chancellor of the University of Nebraska at Omaha, the state's public metropolitan university. The University of Nebraska at Omaha has an enrollment of 12,000 undergraduate students and 3,000 graduate students, a broad public service mission, and an NCAA Division I athletic program. Dr. Gold holds a health professions academic appointment at the rank of professor in the UNMC College of Medicine, as well as the UNMC College of Public Health, where his research interests in population health are concentrated. Dr. Gold is married and has been so for over 40 years to a physician and has 2 adult children, residing currently in New York and San Francisco. We're so pleased that you took the time from your very, very busy schedule, Dr. Gold, to be with us this evening. Please join me in welcoming Dr. Jeff Gold.
Well, good evening, everybody.
Good evening.
Good evening, everybody.
Good evening.
There we go, just making sure that you're still awake. So I want to start off just by thanking you and telling you how pleased and how honored I am to be with you this evening. It's an interesting subject that I was given to talk about the morality of capitalism in the context of rural and urban healthcare, not just in our community, but in America. And I was saying to Charlie a few minutes ago, it's an area that I've been interested in for a long time. And so when the opportunity came to actually bore a few people on a Monday evening, I said, wow, that's a great chance for me to do something. And so I do have some thoughts that I want to share with you, and then I want to leave plenty of time for some question and answer. That's okay. And by the way, it's a great opportunity for me to not be talking about viruses, which I've been talking about all day here. A couple of disclosures for those you may not know it. My undergraduate degree is in engineering. I have nearly completely recovered. I am a recovering cardiac surgeon. I don't think I'll ever recover from that. I've been everything from a division chief to a department chair to a program director to a dean to a provost, a university chancellor, academic health system trustee, system chair, et cetera, et cetera. I've also had the opportunity to sit on and either chair or serve on any number of boards, from the UNMC to the ACGME, the AHA. I mean, this is the alphabet soup of the governance of academic medicine. So it's everything from the American Medical Association to the American Hospital Association to the organization that governs all residency and fellowship education in the United States and Canada. However, none of those opinions am I sharing with you tonight. The opinions I share with you tonight are mine alone. Therefore, I have no conflicts and no disclosures, however, appropriate permissions and apologies. So I have lifted mercilessly any number of images, phrases, etc., from one of my favorite sources of medical knowledge, Wikipedia, as well as a few others, from Google, from the Peterson Foundation, from McKinsey Global Institute, the New York Times, and many, many others. And you'll recognize them. And I've done my best to attribute the images and the words that I've borrowed, and where my attribution has failed, I apologize in advance. I'm not a role model in that regard. So, I've just distributed, hopefully you all have a single slice of a piece of paper that is predominantly blank. I do not want you to do anything with it right now, but I will want you to do something later. And we are going to collectively, over the course of the next hour approximately, answer the question, the future of the health of America is. And I don't want you to answer that now. And in order to answer that question, we have to get into one of the core questions of the morality of the capitalism of healthcare. That is an answer to the question, and I don't presume to know the answer to this, but I want you to think about it for the next 60 minutes that we're together approximately. American healthcare is, fill in the blank, a business serving the markets, shareholders, and others. American healthcare is a profession serving the public. It's both a business and a profession. And if that were the case, it would be the only nation in the world that answers both of those questions. Or possibly, just to, having written an awful lot of exam questions in my life, it's neither a business nor a profession. And I guess the fifth choice is fill in the blank. But, so think about that, because that is the fundamental question as it relates to the morality of capitalism, as it relates to healthcare. Because, if you think about what is a business is an activity of buying and selling goods, manufacturing goods, or providing services in order to make a profit. And this comes straight out of my favorite source, Wikipedia. Business is an institution organized and operated to provide goods and services to society under the incentives of private gain. And indeed, capitalism is one of the unquestionable things that makes this country as successful as it has been. It has defined us as a society for a very long time and continues to do so. And so it's this relationship between businesses and the customer. Products and services go in one direction, and remuneration or gain, in many cases dollars, go in the other direction. And make no two ways about it, dollars are a big deal in our society. This is a chart of the gross domestic product of the United States, and the estimated projection for the year 2020 is 22.3. By the way, that's $1 trillion, if you're not used to looking at all that many zeros. And we'll come back to that number a little bit later, but it is $22 trillion. So, having said that, let's take a few minutes and define a profession. And that comes back to this illustration. For those of you that are not familiar with it, this was actually published by Jean-Jacques Rousseau, known Le Contrat Social, in 1679, a few years ago. And in this treatise of the social contract, Rousseau and Locke and many others over the years talked about what it means to be a profession. Now, a profession, well defined by Elliot Friedson, is a group that reserves to itself the right to judge the quality of its own work. And that is based on three fundamental pillars. The first is that expertise, that professionals have technical knowledge that is not accessible to the general public. Second, the assumption of altruism, that professionals will place the interest of those served above self-interest. And third, the assumption of self-scrutiny, that professionals will regulate each other without the need for outside interference. Expertise, altruism, and self-scrutiny. And that has defined the profession of medicine going back to the days of Hippocrates and before. Indeed, there is no physician in the United States that practices that has ever graduated from an American medical school that is not sworn to the Hippocratic Oath or to one of its variants, which relates to the pillars of the professionalism of medicine. But notice it doesn't say anything about the business of medicine. It talks about the profession of medicine. Indeed, according to Don Berwick in 2007, Don said this is the quadruple aim: better quality of care, better population health, and lower cost of care. So it's accessibility, affordability, and quality of care. Better outcomes, lower costs, improved patient experiences, and less clinician burnout, meaning preserving and protecting the workforce. And I'm not just talking about physicians, but I'm talking about nurses, pharmacists, dentists, therapists, laboratory technologists, the whole show, who work together to deliver on this professional commitment that we call the social contract of healthcare. And that's the contrast that we're going to be talking about together tonight for the next few minutes. So I'll share a few of my favorite quotes with you during our time together tonight. This one comes from Abraham Lincoln, who said that the only way to predict the future is to create it. I happen to believe that fundamentally. And in order to do so, you need to have a mission, you need to have courage, and you certainly need to have a strategy if you're going to build a future moving forward. And indeed, I would not like to spend our time together tonight looking back at the past, but I would really like to take this time to look together at the future, and particularly talk about the existential threats and opportunities, challenges that face us today, and hopefully they will form this delicate balance between business and professionalism. But in order to do that, you need to have vision. Vision brings together the mission, the courage, the strategy, etc. And so let's take a few minutes and just talk about vision. Vision is, again, borrowed from some website, I can't even remember where. This definition: an imagined idea or a goal towards which one aspires. And I particularly like this illustration of vision because I'd like you to concentrate on this photograph for just a minute. Let me just ask by show of hands, how many in this room have ever seen this photograph before? You all, of course, know what you're looking at. So this is actually a male model. This is his left arm bent over the top of his head. This is his painted face. This is his right leg. His knee is bent. And this is his right arm sitting on top of this platform here. Now that I tell that to you and you look really carefully, hopefully you will agree that you can see the model's outline. But I would also hope that you would agree that unless one really focused on the details of this, that you might have just missed that. And you might have thought this was something else. So when we talk about having vision, being detailed and being specific is very important. And so if we're going to have a vision, let's just look into the future, not even to the long-term future. And there are three different choices I'd like you to think about as we go through tonight together. Choice number one, sky is blue, the clouds are fluffy. We're doing fine. There's no reason to consider changes. The existential forces are all congruent with where we're going in healthcare in rural and urban America. Life is good. Choice number two, slightly more ominous looking sky. Perceptions of challenges ahead need to consider some change. And then choice number three, I'm not suggesting any of these, but I'm asking you to ponder as we talk together tonight, is that there's crisis around the corner and we need to initiate not just change, but transformational change in the very near future. Now, in order to describe these different trajectories ahead, my ability to communicate to you is going to be really key, and that your ability to understand and that to respond with thoughtful questions is going to be key too. So I thought I would share a little video with you about the importance of communicating clearly. And this is entitled The German Coast Guard. Now I warn you in advance, the majority of it is actually in German, but I'm guessing for those of you that don't speak German fluently, you will get the idea.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät des Überlebensradar.
This is education as we know it today.
Mayday, mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hallo?
is the German Coast Guard.
We're thinking.
What are you thinking about?
So it is my fervent hope that by the time we're done tonight, you will know exactly what I am thinking about. So, inside of the world of medicine, particularly inside of the world of academic healthcare, there are three critical pieces. There's the research mission, the education mission, and the clinical mission. And the clinical mission, shown here, is larger than the others because it financially drives the rest of the model. And then there are the external public and private forces which have been in place since the days of the early 1900s. And this is all connected, excuse me, by the social contract of medicine. That is to say that if the research, education, and clinical mission interfaces well with the external world, it is all around the professionalism of medicine. So again, that comes back to knowledge, altruism, and self-scrutiny. And this has been the model for hundreds of years of the delivery of healthcare. However, what about the rest of the forces that we face, that we understand that are the internal forces in the world of healthcare, health professions, education, etc.? So there are the funding models, the issues associated with student debt, the issues associated with increasing costs. There are all the issues of accreditation, certification, and licensure, resiliency and burnout of our workforce, the learning environment, the costs and the benefits of research and discovery, and then, of course, the ability to have an effective clinical faculty. And all of that works together with the social contract, which then interfaces with the education, service, and research. And we call that, the entirety of the so-called internal forces. These have been around for a very long time. They're well understood. There's a work in progress. And they are slowly but surely continuing to improve. They are challenges, but those are the internal challenges to the delivery of healthcare and education in our nation. However, it is the external forces, the vision that I'd like you to have at the end of our talk tonight regarding what the external forces are. And here I want to talk about the external fiscal realities, the alternative models of care, the impact of artificial intelligence, robotics, and big data, laws and regulations, social factors, and the political realities of what it means to deliver healthcare today and what some of the forces are that are shaping those realities in the future. Now, unlike the internal forces, these are less well understood. There's been very minimal progress in both understanding and therefore in responding to them. And finally, there's been minimal improvement. Excuse me, I don't need to tell you that these challenges are real. So let's start off. We're going to go one at a time. We're not going to hit all of these simultaneously. But I'd like to talk a little bit about some of the workforce impacts of artificial intelligence, cognitive computing, robotics, and big data. And in order to do that, I'd like to start off with this report. For those of you that haven't seen it, this was published by the McKinsey Global Institute 2 years ago. It'll be 2 years in May. Titled The Automation and the Future of the Workforce. And what the MGI report said was that by 2030, which is, by the way, slightly less than 10 years from now, even I can do the math, 1/3 of U.S. workers will no longer have their current job due to automation, artificial intelligence, big data, cognitive computing, etc., and that worldwide, 800 million jobs will either be lost or changed. 800 million jobs. Now, to put that into a little bit of context, there are roughly 7.26 billion people in the world. 5.11 have a job, at least by some estimates. That was a hard number to come by, but that is the number. And again, that's the number, 0.8 billion jobs worldwide. To put that into the United States, we have about 0.34 billion people, 340 million people. That would mean 130 million have jobs today, at least according to some sources. And of that, we're going to lose about half. About half. 1/3 of U.S. workers, almost a half, will be lost due to automation. So you might ask, in what sectors of the economy? So accommodation and food services, again, this is all MGI data, 73%, manufacturing 60%, agriculture 57%, construction 47%. But even when you come down to educational services, 27%, professionals, healthcare, we're about 36%. For those of you like me who are, quote, administrators, that's about 40% of us, are going to be replaced in one way, shape, or form, according to MGI. And so if you look at the impact of that, again, for just the parts that are relevant to healthcare, and the total spend on healthcare, which is about $4 trillion a year, that would take out approximately $1.25 trillion a year out of the cost of delivering healthcare in the United States. So if affordability is the name of the game, in addition to accessibility of healthcare, quality healthcare. So I'd like you to focus on that number, because that number of $1.25 trillion is going to come back in other forms during the rest of our time together this evening. So I ask you the question, if we're going to be taking $1.25 trillion out of the budget, and if we're going to be taking about 1/3 of the entire healthcare workforce out, what is that going to mean? Where is that going to leave us? So let's go to another area. Let's talk about some of the physical, the financial realities of healthcare. We'll pull this all together towards the end. This is a breakdown, according to the Peterson Foundation, from 2018, of the total expenditure healthcare costs per capita. So the United States spends about $10,000 per capita. Switzerland is the next highest, $7,300. These are the OECD members. United Kingdom, about $4,000. Average about $5,287. Now you might say that's a really good thing because we've got really good, accessible, quality health care in the United States. This is the same out of the same publication, but this shows you the percentage of the GDP, of the gross domestic product. So remember I told you the GDP was about $22 trillion in the United States right now, which is a huge number. So we are expending, at least in this year, which was 2018, compared to our OECD members, 16.9%. It's actually thought now to be closer to 17.5% of the GDP. I mean, the good news is the GDP continues to march up. The bad news is healthcare costs continue to march up faster. And so if you were to compare where we are to the OECD average, you'd see this $1.28 trillion difference. Again, $1.28 trillion per year difference. So start to see a little bit of balance in the sense of we take $1.26 trillion out due to automation, and we've got a $1.28 trillion discrepancy in terms of the economics, the capitalism of healthcare, and maybe there could be a little bit of balance that could be developed there. So let's take that theme and go a little further. This is a look from another well-known healthcare publication known as the New York Times, and it looks at the cost of the delivery of healthcare to you in the United States in rural and urban settings. So bypass surgery, the 100% is here for the US. This is where Australia, United Kingdom, Switzerland are as a percentage. So in each of these categories, there are OECD members that cost less than a quarter of what it costs to deliver, and these are very high quality healthcare environments around the world. Hip replacements, angioplasties, knee replacements, appendectomies, C-sections. So the average, not just the average, but the totality of Australia, New Zealand, the United Kingdom, and others are all less than 50% of the cost of the United States, with comparably good results. This is a look from the same publication at the cost of medications. So this is the same medication manufactured in the same facility, in the same box, excuse me, with the same cost of research, sold in these 5 countries around the world. So 100% here in the United States, and you see the clustering between 15 and 40% at the other countries around the world. Here's Herceptin, here's immunoglobulin, here's Keytruda, here's factor VIII, here's Harvoni, which is a hepatitis medication, by the way, $32,000 for a course of treatment. But if you were in South Africa, it would cost you $3.2 thousand for the same medication, from the same manufacturer, and the same package. Again, it gets down to the question of, is this a business that serves the markets and the shareholders, or is this a profession that serves the greater public? Indeed, there's recent projections done by one of the MIT think tanks, collectively known as New Digs, which I kind of find an interesting name. It says over the next 10 years, there are going to be about 50 new breakthrough therapies that will be approved by the Food and Drug Administration. Think about what you may have read about sickle cell disease. That therapy costs $3 million to deliver to one patient. There'll be about 500,000 eligible patients at a cost of an average of $2.5 million per patient per year. And if you were to look at that, what does that add up to? It adds up to $1.25 trillion per year of additional expense to our healthcare system, sitting on top of everything that we're now doing, based upon these new discoveries. And yet if that patient, that child with sickle cell disease, happens to be your child or your cousin or your niece or a close friend, everybody would want to have that therapy available because it is unquestionably curative. Again, it comes back to this $1.25 trillion number. Just keep that in mind for a few minutes. This is a look at higher education and healthcare education, just to put that into a little bit perspective for you. There are about 17,000 students in universities in the United States today, in public universities, and there are about 3,500 in private universities today. And we all believe in higher education. I hope we do, at least, so you would be sitting in this room. Certainly I wouldn't have a job if I didn't believe in higher education. So all good, right? So this is a chart over the same period of time of the cost of college in corrected dollars. And what you see, the lowest line here is median household income. Again, inflation corrected. This is the rate of inflation, and this is the cost of college in the United States, all in public and private. This compares it actually to cost of buying a flat screen TV over that same period. New cars, this is 0% increase, by the way. Healthcare, that's this line right here. Child care is going up faster than healthcare. And college tuition and textbooks are at the very, very top of this list in terms of the changes that have occurred. And we know this because we track the cost of higher education. This is a chart over that same period of time, except it looks at over 30 years. If you were to graduate today with a doctoral degree other than a JD or an MD or a DO, or a JD, excuse me, or a doctoral degree in medicine, what the cost of that debt, graduation debt is. So if you're graduating with a doctoral degree, in addition to paying back the tuition, you'll give the bank $170,000 during that time. Law degree, $250,000 over the life of the loan. And the average medical student in the United States who graduates with $200,000 in debt will put an additional $380,000 back into the financial institution. So it really hedges the question, is even education a business that feeds the financial sector of our country, or is it a profession that is consistent with the social contract of altruism, knowledge, and self-scrutiny? This is a look at student debt in the United States. In 2017, it was $1.4 trillion. Last year was $1.55 trillion. That's the largest amount of unsecured debt in the United States. And if you balance that out, last year, there was a 15.5% default rate. So 15.5% on homeowner debt, on car owner debt, on credit card debt is a lot different than 15.5% debt on $1.5 trillion. And indeed, if you just look at the health professions alone, just in medicine, forgetting nursing, pharmacy, dentistry, all of the others, just in medicine, that's $265 billion of unsecured debt that's out there today, of which 24%, assuming it gets repaid, will go back to the universities, undergraduate and graduate, that granted the degree, and 76% will actually go to the financial lending industry that provided the debt. Not good, not bad, just a fact. So where does that leave us? So let's talk a little bit about alternative models of care. And what I want to speak specifically about tonight is this concept of disintermediation. Now, disintermediation was a word that I had never heard. So it was a year ago December, not this last December, but a year ago December. You may remember the U.S. markets were in quite a bit of instability. There were large daily fluctuations, not totally unlike what we've seen in the last week or so, including today. And there was a talk show 2 nights or 3 nights before New Year's Eve that my wife and I were watching, and there were 3 or 4 or 5 people who were speaking, and they weren't talking about market trends today or tomorrow or next year. They were answering the question that if they had to buy into the equity markets for their children and grandchildren for a long-term, 30-year investment, what would they want? And 5 out of 5, you know, think Kramer and all those kinds of people, you know, what makes them great, who knows, but they certainly have their opinions. They all said the same thing. They would only buy into companies that were disintermediating their industry. And with the use of artificial intelligence, cognitive technology, etc. That was a really interesting conversation because I had never heard that word. And so yet 5 out of 5 of these people are saying the only thing we can do is invest in disintermediation. So I actually went and looked it up. So again, if you believe in Wikipedia, disintermediation is a noun, and it means the reduction in the use of intermediaries between producers and consumers. It's a business supply chain phraseology. And what it means that typically you have producers, wholesalers, retailers, and consumers, in that if you take out the wholesaler, or if you take out the wholesaler and the retailer and go directly from producer to consumer, you disintermediate the supply chain and you disintermediate the industry. So these are some examples. Uber, the world's largest taxi company, doesn't own a single vehicle. They have disintermediated the industry. Facebook, the world's most popular media owner, doesn't create content. They deliver on that media. Alibaba, the world's most valuable researcher, a retailer, doesn't have a single bit of inventory. Airbnb, the world's largest accommodation provider, doesn't own a single shred of real estate. Each of these companies has disintermediated their sector, and the single most important thing to understand is how have they done it? They've done it through artificial intelligence, technology, cognitive computing, etc. They've done it at great benefit. And so if we're going to apply this to healthcare, the idea would be, how do you go from illness to health and take out the intermediaries? And then if we're really, really good at it, how can we re-intermediate this so that we go from health to health and we can actually, through big data analytics, cognitive computing, etc., cut the illness piece out of the center of healthcare? A pretty laudable concept, right? So let's talk about it. For example, let's talk about diabetes. How many of you in the room either know somebody who has diabetes, has a family member, a friend, etc.? Just sort of raise your hand for a second. I'm just checking to see how many of you are awake, that's all. I'm reassured. So let's talk about diabetes. You probably all know that people feel ill at some stage of their life, some very young, some much older, whether it's increased thirst or weakness, blurred vision, nausea, slow healing of cuts and bruises, etc., even weight loss. Those are the typical signs and symptoms of diabetics. But what you may not know, there are 30 million diabetics in the United States who are being treated today at an annual expenditure of $327 billion a year, which is being fed directly into the pharmaceutical and healthcare industry of the United States. And, you know, these are the steps. Somebody develops one of these symptoms or signs. They call up their local doctor. They get their sugar checked. Aha, there's something wrong. They then call a specialty clinic. They make an appointment. They have a clinic visit. Clinic visit results in a full workup, which, by the way, includes driving, parking, waiting, rooming, exams, labs, treatment, more driving, more parking, and then let's not skip payment in that, which then results in prescriptions, a trip to the pharmacy, medication, feeling well, and the cycle repeats itself. And by the way, in each of these steps, there are charges. That is to say, whether it's the device or the person that does the testing, it's the clerk that answers the phone, the appointment person, the individual that parks your car, puts you in a room, draws your blood, the person that writes and then fills the prescription in the pharmacy. Every one of these has dollars and cents associated with it that not only make diabetics healthier, make them live longer, etc., but feed into a business and a profession. And why have we done it this way? Because since the days that diabetes was diagnosed and since the days that insulin was discovered, that is how we've done it. However, it doesn't have to be done that way. This is a photograph of a contact lens that is actively under development and tested in the United States. It's called a smart lens. And it directly connects to your phone, which directly connects to your insulin pump. So it has an antenna, an LED display, glucose sensor, and of course it corrects your vision. So it acts like any typical soft contact lens. So as I said, what it does is it takes you from feeling well, because it never lets your blood glucose rise above the normal limits. It connects to a sensor device, which then goes either to your phone, to a tablet, or to your watch, which then connects directly to your insulin pump that maintains your glucose within a certain range. And if it goes out of a certain range and doesn't get corrected within a period of time, it not only lets you and your family members know, but it lets your physician, your pharmacist, and others know as well. So it has completely eliminated all of the clinics, testing, parking, rooming, everything. It has disintermediated the healthcare of diabetes. Tooth decay, another one of my favorite subjects. Now, tooth decay, according to New York Times in 1937, was caused by nervous upsets. So this very well-known individual, Dr. McGonigal, wrote this article saying that nagging children at the table and sex repression causes tooth decay. 1937, maybe not too far off. However, in the United States today, $25 billion are expended in the diagnosis and treatment of tooth decay. 830,000 emergency room visits a year, almost 1 million emergency room visits a year. Now, I thought this is what caused tooth decay, these little green gremlins that sort of crawl around your teeth. But actually, that is not the case. They're caused by a series of biochemical reactions, which is predicated on a certain protein called a leukotoxin that lives in your mouth that then binds to your teeth that causes this cycle of decay. And of course, we have a whole process. You feel well, you feel ill, you get pain or some other thing, you call the clinic, you schedule an appointment, you see the dentist, go to the emergency room. You know the cycle as well as I do. There's not probably anybody sitting in this room that hasn't experienced that cycle. However, there is a brand new type of toothpaste, for those of you that are toothpaste fans, that when you use a brand new type of toothbrush that emits a certain frequency of laser light, it inactivates leukotoxins, and it makes the development of tooth decay impossible. Now, what happened to the dentist and to the hygienist? What happened to the people that create the fillings? What happened to the people that manufacture the equipment for the x-rays and the scans and all the rest of the stuff that's in this long food chain that connects both to the profession of oral health and to the business of oral health? Every single one of them is disintermediated. And by the way, if this continues to work, you're never going to get that decay, you're never going to get that pain, you're never going to show up in the emergency room or your dentist's office, because this will be stopped at an earlier stage. But the economics of this doesn't go into the healthcare profession. The economics of this goes into the manufacture of these oral gels and the toothbrushes that happen to emit this unique brand of laser light. Again, disintermediating it. So one would say that anything that has a biomarker, which means you can measure a sign or a symptom, a chemical abnormality, such as glucose in diabetes, such as leukotoxins in oral health, and on, such as certain markers for cancer, certain markers for depression, certain markers for pregnancy, etc. Anything you can measure a biomarker for in the world of automation and robotics can be prevented, screened, and ultimately treated, and be completely disintermediated. At the savings, by the way, of trillions of dollars. Again, the number about $1.4 trillion. So let's talk about health security for a minute, one of my favorite subjects these days. Health security, at least defined by our national friends, is the national state in which we are prepared and protected and resilient in the face of threats, incidents, and potentially negative health consequences. So I'm talking about things like tornadoes, hurricanes, wildfires, floods, things of that nature. Or I'm also talking more specifically about CBRNE, which is chemical, biological, radiologic, nuclear, and environmental hazards. These are the things that keep our federal government up at night, keep us at the Med Center up at night a good deal. And these CBRNE things, chemical, biological, radiological, and nuclear, are protective measures taken in situations in which we are confronted by that, both naturally occurring and non-naturally occurring. So a chemical spill or a nuclear plant accident like Fukushima would be in the category of, quote, naturally occurring. However, currently we're 28,300 American servicemen and women in South Korea, and the question came up not too long ago, what would happen if they were exposed to a chemical or a radiologic nuclear event that was not accidental? And what would happen to those people in the future? So we are ranked every year. So nationally, we're ranked in the 10 regions, but we are ranked nationally 6.7 out of 10. And just to give you a rough idea, surveillance 7.5 out of 10, community planning 3.9, incident management 7.9, healthcare delivery 4.5, particularly low in rural America, countermeasure management 5.6, and environmental and occupational health about 6.1. So fast forward to today. Let's talk a little bit about coronavirus, also known as COVID-19. Until December 30th of last year, nobody had heard about this. Coronavirus is a virus widely present around the world. It's the same family of viruses that causes SARS and MERS. It causes the common cold. They call it a coronavirus because it has these little spikes on it. It looks like a crown. But all of that has changed. This is off the Hopkins website today. As of midnight last night, there were over 90,000 confirmed cases around the world, just over 3,000 deaths, and about 45,000 individuals recovered. This is a look not at the total number of cases historically, but the total number of diagnosed cases today. It is currently thought this number is off by a factor of 20. 20. So there are 20 times higher number of individuals around the world that currently have this diagnosis. And I mean around the world. This is a photograph in Wuhan, China. The people in Wuhan, which is in the central part of the Hubei province of China, over a 3-week period built 30,000 hospital beds. That would be 30,000 hospital beds. And they are still totally maxed out in terms of their ability to care. This is an interesting statistic that I'd sort of point out to you. This goes back to the SARS days. There were just over 8,000 total cases of SARS worldwide in 2002, 2003, also a coronavirus infection, and there were 774 deaths. To put that into perspective, documented in China alone today, there are 80,000 reported cases and 3,000 deaths just in China. By the way, there were 6 more deaths in the United States today, to give you haven't been tracking the news. However, during the same time period, a small number of people traveled to Canada, a total of 358, of which about 50 passed away. This is not the incidence of the disease, ladies and gentlemen. This is the gross domestic product of the entire country of Canada. So here is when the first cases of SARS were reported in Canada in the third quarter of 2002. Over the next 3 quarters, it dropped to a negative number. And these 358 cases caused a 4-year recovery back to the same gross domestic product in Canada. And all due to fear, panic, supply chain interruption, etc., for 358 cases. It is currently estimated that there's somewhere between 8,500 and 10,000 cases in the United States today. We just don't know where they are. And the fortunate part about it is that most of all of these people look well, feels well, go to work, go to school, etc. And for many of them, they're in that 14-day period before they become symptomatic, when they are truly feeling well, but still actively shedding virus. And finally, I'd like to talk a little bit about the political realities of our payment system, and just to make a few points that hopefully are obvious to this audience. That we have the most complex health information, record-keeping, finance, and documentation system in the world for our healthcare. There is no single repository of data. And those large repositories are completely privatized into both public systems and into private systems. And this is not a comment about whether public is good or private is good, or a combination is good or bad or indifferent. This is just a comment about how complicated the systems are, how they don't communicate with each other, how they're not portable, they're not transmissible across state borders, etc. But what you may not know, about 55 out of 100 people in the United States either are covered by Medicare, Medicaid, TRICARE, other federal governmental payment systems, etc. So whether you believe that public options are good or bad, whether you believe that a single payer system is good or bad, we've got the best or the worst of both worlds. And by the way, a very vibrant private payer system as well. However, there's a lot of work that's been done on creating a hybrid public-private system. And I like to call this the red, white, and blue system because I had something to do with designing it, but it's been called a lot of things, but the best known phrase is called the Medicare X systems. And the reason I like to call it the red, white, and blue is it brings together all of the neutral aspects of health information, records, finances, revenue cycle management, etc., with the best of the public sector and the private sector without having to blur the two. And for a lot of reasons, this public-private option has been widely talked about in the halls of Congress. I'm not going to bore you with all of the details, but its goal was to stabilize the availability of at least one option, one affordable option in the United States that would appeal to the red side of the aisle, the blue side of the aisle, and that those people in the middle that didn't care what color your politics happened to be. Because traditional Medicare has a proven record of providing portable, high-quality care, Medicare Advantage, which is the largest growing sector of private health insurance, has been extremely successful, etc. And so having one single system that could be an option, not a mandate, but an option, is highly attractive. So these bills have been introduced in Congress. There's one in the Senate, there's one in the House, and without boring you with the details of the so-called Medicare X bills, they've all been marked up by the Kaiser Family Trust. And what the Kaiser Trust says, that the administrative savings alone, just for an option, not for a mandate, just for an option, public-private option, would save $0.7 trillion a year, reduce spending by $0.5 trillion, and would save our entire healthcare system $1.26 trillion. Again, coming right back to that same number of $1.25 trillion, just for putting public-private options onto the market today. Again, no mandates. So I guess that comes back to the question of where are we? You could say this is the perfect storm between disintermediation, social factors, political trends, workforce demands, economic modeling, technology, healthcare policy. It really hedges the question about the morality of capitalism in so many different ways. And so I point this number out to you. This number adds up. This is, by the way, this is what $1 trillion looks like. So this would be 2 trillion, 3 trillion, 4 trillion. This is $4.1 trillion stacked up, just to give you an idea of how many zeros we're actually talking about. So let's do a little math together for a minute. Current U.S. healthcare spend, $4 trillion. Of our peer OECD organizations, countries, 2.6 trillion. Gap there, about 1.4 trillion. And indeed, if you were to talk to Mr. Buffett, and I've heard him speak about this, and maybe you have as well, about American healthcare, he's not critical of the quality or the access. He's not critical of the technology and the capitalism associated with it. He's critical of the fact that $1.4 trillion is an impediment to American businesses that are keeping them from competing on a global stage successfully. So this disproportion is 1.4 trillion. We've talked about the unsecured student health profession's debt of 0.5 trillion. We've talked about the impact of annually $1.4 trillion due to these new designer drugs. And we've talked about the estimated impact of failure of health security in our country at about $1.5 trillion a year. We've also talked about the savings that could occur from workforce reduction due to artificial intelligence, the efficiency of healthcare spending, the disintermediation, the reintermediation benefits. And of course, if the red, white, and blue or the Medicare X bills were to go into place, a savings of about 1.3 to 1.4 trillion dollars. And the interesting thing is, when you add up both of those columns of the red and the green, that they almost exactly balance. So if we were looking at the future of healthcare in America, we are talking about forgetting the altruistic, humanistic sides of it. Over the next decade, we're talking about shifts as much as $5 trillion a year is at stake here. And it really hedges the question for all of us as to where is healthcare going, and do we have an appetite to make these kinds of changes in order to create an accessible, affordable, high-quality healthcare system in this country. And so, are we doing fine and no reason to consider change? Do we perceive there are challenges ahead and need to consider some change? Or are the skies pretty cloudy and there's crisis around the corner? Do we need to consider just change, or do we need to consider transformation? So the exercise, of course, is to think, and that's why I'm here with you tonight. Not for me to think, but to get you to think, and to think bigger about these challenges. So there are many ways of thinking bigger. I'm enamored by several of them, for those of you that are not familiar. One is called the big rocks process. That's the Covey idea, that you got to put the big rocks in before you put the small rocks in, and then you put the sand and the gravel in, and then you can add the water. Because if you start with the water and the sand and the gravel, you can't get the big rocks in. There's something called future scenario thinking, which is build a strategy and then stress test it in the future to see if it'll work in a future world. Breakthrough thinking, design school thinking, which comes out of the Stanford University School of Business. These are all fabulous things that I'm very enamored with and have used a lot of. There's something called impossibility thinking, which we're going to do together in just a few minutes. And then there's something called toothbrush thinking. And I don't know, how many of you are familiar with toothbrush thinking, coming back to our dental decay model? We'll talk about that in a second, but let me just show you these first. These are the 12 big rocks. And whether you did this through the big rocks thinking, etc., these are Jeff's 12 big rocks, by the way. They're not yours or anybody else's. They're not the university's. But I would say the first 6 are to embrace the social contract, to recognize the risks and uncertainties we've talked about this evening, to focus on the quadruple aim, to determine and align the incentives, to optimize value and not just cost, and to strengthen the workforce. And then the other 6 are to build from academic experiences, that is to say, build from facts and science, and not build from fiction, to create scalable resiliency, to plan transformation and not iteration, to engage in novel public-private partnerships, to disintermediate future systems, and yes, by the way, when necessary, to ask forgiveness and not to ask permission. And while a wise person said change may be difficult, I would suggest to you that over the next decade, not changing is probably going to be pretty fatal. So this has to do with the toothbrush test, for those of you that don't know it. Google, a company my son's worked for many years, I learned has a toothbrush test, and it's the 80-20 rule of working for Google, and that is to say 80% of the time you have to do whatever your job is. Work for the company, whatever that happens to be, and there are a lot of people that work for Google and love it, by the way. But 20% of the time, you can do anything you want, anywhere in the world you want to do it, as long as it passes the toothbrush test. So what's the toothbrush test, right? Let's go back for a second, if you don't mind, before I take you to Mr. Mandel. The toothbrush test is pretty simple. Every human being alive has to use it twice a day, and it has to change the world. So every human being alive does what you want to do, potentially use it twice a day, and it changes the world, passes the toothbrush test, and every one of the Google employees can use it. That's the kind of thinking that's going to be necessary to walk through some of these challenges. So in closing, I would say the following. 1, I hope your choices, as you think about this balance between professionalism and business, reflect your hopes and not your fears. One of my favorite sayings of Nelson Mandela. And then I'll share with you a quote from Jim Collins, another one of my favorite medical experts. For those of you that truly dislike change, you're surely going to hate being irrelevant. He wasn't kidding. So here's my challenge for you tonight. Now is when I want you to take out that piece of paper. And I don't want you to write on it just yet, but I just want you to look at it. So I'm going to ask you to keep it. And here's what I want you to do. I want you, either tonight or tomorrow or sometime, when you're alone, when you've had a chance to reflect on what we've talked about, I want you to take a pencil, and I want you to cross out the letters I-M in the word impossible. And then I want you to answer the question. The future of the health of America is possible. What is possible? And the criteria has to be, it's something that today, tonight, yesterday, each of you thought was impossible. What is possible if you think broadly? What is possible if you really try to create the future, as opposed to be subject to the existential threats and concerns and challenges that we face? So I thank you for your time tonight. I'm more than willing to answer any questions that you may have if time permits. If not, please feel free to email me with all of your suggestions, thoughts, criticisms, etc. So thanks a lot. Yeah, sure.
Thank you. I'll pass it around here. Questions?
Most of you do seem awake, which is very reassuring at this hour.
Dr. Gold, how do you relate all of this to the humanistic approach of medicine? I mean, artificial intelligence, we had a nice talk by Dr. Wendell today on artificial intelligence, and there seems to be a trend in our universities to de-emphasize the humanities. Well, I think us that are in the field of medicine, whether it's as a physical therapist, a pharmacist, a dentist, a physician, PA, we're kind of losing the humanistic approach to medicine because we've shifted from doctor time to business time.
So over the last decades, at least 2 decades, the trend that you just referred to, the dehumanization, the insertion of technology, has undeniable. It's put keyboards and screens between doctors and patients, nurses, pharmacists, etc. The current thinking about the people who really understand the use of artificial intelligence and cognitive computing say that it's going to rehumanize the practice of medicine because the technology will become invisible. You know, I'm very closely tied to some of my friends and colleagues that work for Apple and work for Microsoft and others. And they talk about making the technology invisible, that the human-human interface becomes the deal. There's a man named Daniel Surfati, who you can look him up, but he's written extensively about the use of cognitive computing, not in healthcare, but for the military, for commercial aviation, and other things. And what Dan says is that the cognitive ability of the machine is here, the cognitive ability of the human being is here. If you put them together, they're here. So it's the human-machine interface that's going to provide the best access, affordability, and quality of care. And it's also going to rehumanize the interface. You know, you talk to the people at Apple or Microsoft or others, IBM, they would tell you the best computing systems in the world are invisible. You don't even know they're working. It's all about the experience. It's not about the technology. So I think we're going to be seeing a whole generation of high-tech and high-touch healthcare. You know, where there have been a lot of surveys done, and for typical routine care, you know, I think about my grandchildren who are 3 years old, or, you know, if my kids want to look something up, they just go online and they look it up. They get an answer. So for well baby care, that works great. I can tell you, I've spent 25 years of my life taking care of little babies with heart disease. It doesn't work like that. I mean, there's no mom in the world who's going to hand her baby over to you to do open heart surgery who doesn't believe in the human side of what's going on. Because if there's no trust, there's no connection, identification, all will be, I think, will be permanently lost. So I'm actually encouraged that the technology, the disintermediation, the getting rid of the bureaucracy of the revenue cycle management, having public-private options that create true affordability and access will allow the healthcare industry to focus on what's really important, which is the relationship with our patients. That's what I went into healthcare for, and that has never changed. Any other questions? All the way in the back. I knew you'd have something.
During this time of transition, do you think rural health systems are more vulnerable than urban health systems? And if so, why or why not?
I don't think they're more vulnerable. I think it's, you know, I'm fond of saying, and I believe this to be the case, that all healthcare is local. And you look at one state, you look at one rural community, you've got an N of one. So what works in Kearney may not work in Grand Island. What works in Grand Island may not work in Scottsbluff. It's just very variable. But the current system of critical access hospitals and the distribution of resources, and particularly workforce resources, is going to be the single most important determinant. Because you can build the most beautiful buildings in the world, unfortunately financed with a considerable amount of debt. And you can have the best coffee in the lobby. But if you don't have skilled, stable workforce to deliver that care, it doesn't make any difference. And the rural workforce shortages are really going to be what's going to determine access. Now, telehealth and distance learning and those sorts of things are going to have a very large impact. But at the end of the day, it's going to be networks of care delivery and the use of cognitive computing and artificial intelligence that's ultimately going to either cause survival or not survival of rural America. You know, you think about it, what does it take to make any rural community prosperous? They need a certain number of businesses and economic development. They need K-12, maybe possibly higher education. They need a couple of bars and saloons here and there to keep the community engaged. And they need health care. They need health care, and they need reasonable access to health care. So I mean, it comes down to a very, very critical question, you know, right to the morality of capitalism. Let's talk about obstetrical care. Because every single one of the 93 counties of the state of Nebraska need high-quality obstetrical care. In the best of all worlds, sure, totally unaffordable. So is it better to have quality of care that is such a small scale that a critical access hospital does 1 or 2 or 3 deliveries a month? And by the way, is that where you're going to want to have your child or have your family's members have their children? Or you want to drive an hour and a half or 2 hours, be helicoptered in an emergent situation to a place where people that do hundreds of complex deliveries a year. That is, there's no right or wrong answer to that question, and you all have your opinion. So the good news is that if you're going to have an absolutely normal delivery, uncomplicated, you can deliver quietly. You know, it's been going on since time immemorial. But when something goes wrong, and you've got 90 seconds to figure out what the problem is and do something about it, it's too late. You know, it's like what Governor Ricketts said this morning. We're talking about coronavirus disease, and we're talking about the fact that the coronavirus spread is like snowstorms. We all know here in Nebraska what to do when there's a forecast for a heavy snowstorm. Just like our Floridian friends know what to do when they're forecasting a hurricane. They get supplies. They make alternatives for childcare. They know what they're doing with their aging parents. They stockpile medication, things of that nature. And then they sort of batten down and they wait for the snow or the hurricane or the flood to pass, and then they dig out one way or another. We understand that. We don't start to put the plywood up after the hurricane has hit the shore. We don't want to put the plywood up on American healthcare when it's so dysfunctional that there's no access in rural or urban America. Now is the time to think these big thoughts. Now is the time to make some changes. Anything else for the good of the order? Well, thank you so much. It's been a real... Did you have a question?
Yeah, I just wanted to give you an opinion about how the United States is going to be affected by AI and healthcare industries compared to other countries that have government funding. Can you comment on that?
I think we're going to be, you know, compared to the OECD countries, I think we're going to be about average. You know, there's a lot of work being done with cognitive computing in healthcare right now. You know, I just, you know, I wear my little watch here. It tells me how much I sleep, what my heart rate is, what my body temperature is, you know, etc. The good news is I'm healthy today. If I need this to tell me I'm not healthy, something's wrong. But, you know, just to give you an idea, I mean, we're doing a clinical trial now on Parkinson's disease using these devices where we have 400 patients in rural Nebraska who are being activity monitored through activity monitoring activity. And they feed into a database, and if there's any change in their daily activity, we call them up, we change their medication, etc. And otherwise, they don't need to come in and they don't need to drive hours to see our Parkinson's or our Lewy body or our Alzheimer's specialist. It's all handled by the device on their wrist. Saves them money, saves them travel, saves their family members, and keeps them healthier. Disintermediates healthcare. So that's a really good example of how it's already here in our country. Well, thank you again. Have a wonderful
Dr. Gold, one more time. Thank you.
You're very welcome.